Hello, everyone, and welcome to today's webinar, Equity's Role in Social Determinants of Health Interventions, Research and Evaluation. My name is Archer Rogers, and I'm the Director of Programs for the California team here at Health Leads, and I'll be moderating today's conversation. Now, for those who may be unfamiliar with Health Leads is an innovation hub that runs both national and local initiatives that address the deep societal roots of racial inequity that impact our health. During COVID-19, we've seen Black and Brown communities disproportionately impacted as a result of structural racism and white supremacy. Health Lead's work has focused on helping communities both respond to immediate essential health resource needs and also rebuild equitable systems for the future. And as we begin to rebuild systems, we must ensure we are not replicating or reinforcing the deep inequities in how those health, justice, and education systems operate. And we need to intentionally and explicitly uplift racial equity. Now, it would be remiss of me if I did not mention that healthcare has a long history of perpetuating racial disparities and inequitable outcomes, especially through research and evaluations. Infamous studies like the Tuskegee study of untreated syphilis have illustrated the unethical treatment and mistreatment towards communities of color within healthcare. With this legacy, research and evaluation efforts in social determinants of health interventions must be vigilant to not perpetuate inequity and or racism. Now, during this webinar, panelists will highlight equity-oriented methods used in social determinants of health research and evaluation, discuss best practices and lessons learned, and explore the opportunities to integrate equity into social determinants of health research and evaluation efforts in our current context, especially with the call for justice in the midst of a police brutality crisis. And with that, today we have 3 health equity champions who have graciously given their time to delve into these issues and more. First, we have Etsemaye Agonafar, health services researcher and internal medicine physician with the Department of Health System Science at Kaiser Permanente's Bernard J. Tyson School of Medicine. Tamara Cadet, associate professor at Simmons School of Social Work, and Adam Shikadance, who is a pediatrician and health services researcher with the Department of Pediatrics at the David Geffen School of Medicine at the University of California, Los Angeles. So, welcome everyone. And let's get started. I just referenced the Black Lives Matter movement. Well, similar to the Black Lives Matter movement, communities, particularly Black and Brown communities, knew that social determinants of health existed and that they mattered. These communities have felt the impact of social determinants of health for decades, if not centuries. We have even seen researchers in the health equity and health disparity space spend many years highlighting the importance of social determinants of health. So I want to start our conversation by asking you kind of a twofold question. Why has social determinants of health become such a popular topic in healthcare research in recent years? And also, why is that primary focus of social determinants of health research and evaluation been primarily constrained to, one, proving that social determinants of health exist, and then also proving that addressing the social determinants of health is actually worth investing in based off of health priorities? So I know I asked kind of a loaded question at the beginning, or loaded questions, but I really would love for you to really talk about the evolution of social determinants of health research and evaluation. You know, it seems to be a popular thing to talk about and to evaluate. And it also seems that social determinants of health has really been constrained to, one, showing that it exists in communities, and also proving a value case based off healthcare priorities. And I'm just wondering what your perspective on that is. And I would love for Tammy, if you wouldn't mind starting us off with this discussion.
Sure, thank you. I'm so happy to be here with these esteemed panelists, Adam and Etsemaye. So as you were talking and I had been thinking about this, it occurred to me that there was a shift in healthcare from sort of fee-for-service to value-based care. And when you think about value-based care, which ultimately says, okay, we've got to have positive patient outcomes, it means that you have to focus on the whole person and the whole patient and not just what the patient or the client brings to you. And so, you know, that patient, their client that comes to us in healthcare, that's just a snapshot of their world and their life. And any issues that are related to social determinants of health exist long before they see the providers. And so I do think, you know, you started to talk about healthcare priorities. It was about healthcare priorities. It was about money in some ways. I think that in sort of the way that we tend to operate as a society, we don't believe something until it's proven by the evidence. And so we have to describe and describe and describe. And, you know, at some point we say, okay, I think we've got enough description going, so let's do some interventions. But we need this evidence to say that it's okay for us as professionals to say, oh, these are important. We just don't sort of pull them out of the air. We've got X, Y, and Z person saying that. And then when we have that, then all of a sudden there is the funding and the resources to support that. When there was, quote unquote, no research, then there was no funding. You know, and you started to say this, interestingly enough, you know, social workers and public health professionals have been thinking about social determinants of health for a very long time. We teach social workers to assess the entire patient, if the entire patient or the entire client, if they've got one problem, well, we have to ask about housing because maybe that's connected to the problem. So I think that those sort of comprehensive assessments that certainly we use in social work that use slightly different in public, if you're a public health professional, and I'm sure Adam and Etsemaye can talk about sort of physicians, that's assessment is what you do to sort of figure it out. And it's been happening long before the research happens. And that's in part what we teach, at least students of social work.
Thank you for that, Tammy. I thought it was really interesting how you talked about really one healthcare priority, and you talked about money. A lot of times we're thinking about it from utilization outcomes or clinical outcomes, but you really talked about this shift in payment that kind of shifted the need to actually pay attention and recognize social determinants of health. And Etsemaye, I want to pull you into the conversation to really expound upon that, and particularly like that perspective intersection with equity, or things being, you know, inequitable.
Right. So as Tammy mentioned, the shift to value-based payment is a new thing, and has resulted in sort of these new programs that are asking healthcare to do things that they haven't really done before. And as a result, there's really no evidence to support how to effectively ask these questions of patients or clients and then be able to plug them in with the resources. So with no sort of framework of how to do it, we're sort of left to our own structure to go about dealing with it. So if we accept the fact that our systems already have inequities before we try to address social determinants, it's sort of by default that we're in this place that we're creating programs that may perpetuate disparities or inequities that already exist. With programs that we see here in Los Angeles County that are really trying to address social determinants by linking patients with resources like Whole Person Care Los Angeles, we haven't quite figured out how to do it effectively. And, with my work in the county jail, I get to see firsthand how programs with the most well-meaning intentions are failing the end user. And it's really because, we haven't established a system that holistically thinks about the client, or holistically thinks about how to implement a program that meets the client or the patient where they are.
Thanks for that, Etsemaye. I was really struck about the fact that, essentially we're doing this work in an equitable system, so it's no surprise that we're having inequitable approaches or different approaches and how social determinants of health are implemented and evaluated. And Adam, I just wanted to bring you in to see if you're seeing that same, if you have that same perspective. Are you seeing that in the landscape as well? And Adam, you're on mute if you're speaking.
Appreciate it. Thank you. That's the story of 2020 for me. Thanks, Artera. So yes, there's immense variation in what people are examining and implementing. And I think we don't talk about that enough. The variations themselves. I think, and when I say we, I'm referring to sort of social determinants of health interventions in healthcare broadly, and also researchers in this space who are trying to figure out what the programs that work are and why they work, what the reasons for how they work are. We don't talk about those differences enough because there's sort of a medicalization, I think, of thinking about behavioral interventions in the social determinants of health space. We want to sort of default to the idea of research and implementation and intervention work in this space being similar to standard medical interventions, where you have a known dose, you have a standardized procedure, you have tools that are really quantifiable and very concrete. But these interventions are much more fluid, they're much more dynamic, they're much more dependent upon the relationships and the cultures in which they are implemented to a certain extent. I mean, obviously, healthcare culture influences a lot of other procedures and practices, but I think it's worth emphasizing that there's all this variation in implementation and in context that really does have a huge impact on the effectiveness of the programs and the way in which they can be translated, scaled, disseminated. And if we surface that, I think we'll get to that later in the conversation. If we're able to surface those differences, look under the hood of those interactions, and really be able to say, this is what worked, this is why it worked, and this is for whom it worked, right? And piece those things together, we'll be able to advance the field much more quickly, to Etsemaye's point, and we'll be able to make much more progress and be much more effective, to Tammy's point. And I'll also say, to Tammy's point, it's so important to mention that even though value-based payment is new, and in healthcare we're sort of figuring all this out again and relearning these lessons, the fields of social work, the fields of social science, the fields of epidemiology, and this is not new information, right? It's just a matter of us accessing that wealth of knowledge from our colleagues in those fields to get up to speed, right, and to implement more effectively.
Thanks, Adam. I think this kind of transitions into the next kind of topic, when you really talked about looking under the hood to see what works well for which populations, and what are the approaches that worked well for different populations, what were the unique benefits for different populations. I wanted to know, and just hearing your experiences, what are strategies and tactics that you have deployed in your work that has really elevated racial health equity and the interests of communities when you're doing the social determinants of health research and evaluation? And wanted to start with you, Etsemaye. Would you mind sharing what strategies that you've used?
Sure. As a person who's sort of deeply committed to achieving health equity and justice for underserved communities that I'm a product of, I've had to find ways to sort of protect my personal mission from being watered down in some of the systems and institutions that I've trained and worked in that are mostly, as Tammy sort of mentioned, driven by that financial incentive. And sort of the most effective way that I've found to do this is by making sure that my research always lives in this intersection between sort of community partnered participatory research and implementation science. So it's not only sort of creating opportunities to amplify voices of community, but incorporating those voices into the design, implementation, and evaluation programs so that collaboratively with community, we can leverage their existing assets and needs. A prime example that comes to mind is sort of my partnered work with Healthy African American Families in South Los Angeles. Together, we built a community coalition called Communities for Wellness Equity. This was an effort to continue the legacy of the late Dr. Loretta Jones, who was a pioneer in CPPR. And before she passed, she noticed that social determinants of health was becoming this sort of hot topic that lacked community's voice. And so we applied her approach. And as she would say, we got the perspective of those with a PhD of the streets. We made a seat for them at the table and ensured that other stakeholders were present and listening. And in sort of a day-long community engagement symposium, we used audience response surveys, focus groups, large group discussions to really understand the community's definition of health and wellness, how they viewed their assets of their community, and then had them prioritize the social determinants of health that came up. And really, it wasn't much of a surprise. They identified housing, food security, trauma, education as their priority. But interestingly, overwhelmingly, all of them identified structural racism and discrimination as the underlying cause of their disparities. So now that we started that initial asset and needs assessment, we're developing a community leadership institute where we're going to have working groups in each of their priority areas to try to develop new programs or improve upon new existing ones, ask new research questions, and then hopefully address some of the local and state policy. And so I use this example because this is the type of research that really moves us forward beyond just getting feedback from the community about a program or an idea that we have. It's about being inclusive and having community at the beginning of a process, sharing power with them. And it's work that's really centered in sort of humility, selflessness, and care and love for individual stories and lives, of the people that we're researching. And it really requires you to be a true partner with the community. And first and foremost, you got to accept up front that this takes a lot of work, but the hope is that there's a huge reward at the end. And I think, as Tammy mentioned, it's about building trust with individuals that have perspectives that are different than yours and finding sort of the win-win for all parties involved and really focusing in on the assets and strengths of the community as opposed to sort of the deficit framing that sort of gets tagged in with social determinants of health. But that's one of many strategies, and I can ramble on forever.
Yeah, no, I really appreciated what you really articulated, Etsemaye, centering the community, understanding that it takes time, but shifting the way that we approach communities, looking at it from an asset-based perspective versus a deficit-based perspective, which oftentimes is unintentionally or intentionally interweaved in some of these social determinants of health programming that we implement. And I loved everything, that you said, coming from communities and seeing systemic racism personally. I know that, and I see this even within the chat, so I'm trying to make sure that I interweave some of this too, but there is this tension of doing the work that you're talking about, Etsemaye, of being centered in community, but there's also this aim around cost effectiveness, cost reduction. How do we, I think there's a question that's how do we measure, cost effectiveness of these interventions? And so Adam and Tammy, with centering on what Etsemaye is saying, how do you balance bringing in the community, uplifting the community, especially because you're researching and evaluating these communities that have had this history of systemic oppression and even systemic oppression done in healthcare research. But how do you balance that with the healthcare priorities of cost effectiveness, cost reduction? So Adam, I want to ask if you could jump into that, and then Tammy, want you to be thinking, want you to come into the conversation after Adam. And you're muted again, Adam.
Thanks again, Artair. You asked a layered question, and we're talking about sort of a layered phenomena here, right? There's the importance of sharing power at the level of the community program interface, and there's a level of sharing power between the programs that serve communities that have been historically marginalized and disenfranchised and the health system in which they operate. And I think what you're speaking to in surfacing this pressure that a lot of us feel to justify the work that's being done around social determinants of health at a level of evidence that hardly any other intervention in the healthcare system is held to, right? Frank return on investment, right? More dollars back for the dollars that are spent, which is, that no pharmaceutical intervention, no surgical intervention, no other intervention in healthcare is asked to perform at that level, and yet that's sort of the goalpost that we've either set for ourselves or feel as though is the level of evidence that's needed to justify the work. I actually think the answer to your question, or the approach that is most effective is actually what Etsemaye was describing, which is not falling into the trap of thinking that we need to a level of evidence that's outrageously high in order to justify the work that we're doing, or to serve the communities that we want to empower, right? So in that power sharing, we are actually able to say no. Addressing people's food insecurity, addressing their housing insecurity, addressing their stress is enough in and of itself, right? And we know we don't need to sort of prove again that that's worthwhile to do. We know that's good for people. We know that's good for health, and we don't need to waste our time reproving those points. That frame shift, right, towards sort of self-empowerment as a field, I think would go a long way towards us shedding ourselves of these expectations. Now, don't get me wrong. I do think that these interventions have tremendous power, and we should be measuring the impact that they deliver. But I don't think we should frame anything short of dropping readmissions within a month of developing these interventions, deploying the interventions. That's if we don't meet that bar, it's not a failure, right? We have a long ways to go. I think of this field as sort of where cardiac care was 60 years ago, before we understood, how to address, all the risk factors for cardiovascular disease. We didn't have statins in our toolkit. We didn't have, all the diagnostics that we have today, but we knew that it was really important to address. And I think that's where we are with social determinants. And in the next 20 years, we'll have, the EKGs, the echoes, and the statins to move us towards a more precision social determinants of health intervention.
Yeah, I really appreciate how you're talking about how we have to check ourselves on not falling into the power dynamic or perpetuating a power dynamic or power construct of this is what value is, especially to communities who are often undervalued, underappreciated. And I loved how you started to integrate, and Etsemaye was doing this as well, really focusing on power sharing. And so, Tammy, I wanted to bring you in to talk a little bit about that. You can address some of the things that Adam said as well, but really talking about what it means to do power sharing, and also some of the difficulties that may occur when you have institutions who may not want to power share with local communities, local CBOs, and the historically marginalized. Any tips around that?
So a couple of thoughts. Etsemaye, I love those who have the PhD in the streets. I am going to steal that. That is just perfect. And I think about that sort of in the context of I'll get to a point around, this idea of equity and social determinants of health is a multi-pronged issue and a multi-pronged approach. And I've seen some bits in the chat around sort of leaders in boards, and there's certainly those folks that are involved, which is part of the power structure. But I was reminded as both Adam and Etsemaye were talking about a quote that comes out of one of the books around, if we don't consider the patient's milieu environment, then programs are ineffective. And so if we just think about what it means to be effective and think about the fact that we have not included the lived experiences of these folks, then it is ineffective, period. It could be effective maybe to the government. It could be effective to your funding sources, but it is not for the person and the people and the populations that we are supposed to be caring for and making sure that we can increase access in all cases. I do think Etsemaye talked about sort of community-based participatory research, and for me, that stands out. It's hard, and make no mistake, and I have made a ton of mistakes trying to do it, and I'll give you a couple of examples, but really this idea of power sharing. Of course, as a social worker, I'm certainly trained to respect the client. The client is the expert. They own their own lives. Certainly as a public health professional, I'm supposed to share information and ideally motivate them to do X, Y, and Z. But as a researcher, I'm trained that, gosh, I've got the data. Don't ask me where I got the data from, but I've got the data. I've analyzed the data, and therefore it is. And that's how we're trained. And yet, that's not how it is if that doesn't tell the real story of what's going on. And so it is about, Etsemaye, I think you mentioned the idea of humility and being humble. Our goal, in addition to, where we need to be trained is, yes, we need to learn all these wonderful techniques about working with patients and populations at both the personal level, but as researchers around the need to be humble and the need to recognize our biases. And part of that is we need to share, if not give up, all of the power. It is their stories. I recently heard this week, and I don't know why, I just thought about it today, that quote that I think the disability community uses is something to the effect of not about us without us. And that should be the mantra we take. Not about them without them. And that looks like many different things. And so when I think about power sharing, that certainly starts with me as the individual researcher. That means sort of the communities that I've gone into, and I've gone into some communities where I will admit we went in, we collected the data, and we left. So why the heck don't they trust us? Because we promised something and we didn't deliver in the way that they needed to be delivered. Certainly in the way that my manuscript needed to be delivered, but not in the way that the community that took the time to say, sure, we'll share our experiences with us. And so I think there is this idea of how do we humble ourselves? How do we find that one person? Because you know what? It starts with one person. We can't just say, okay, I'm going to go find 50 people who meet X, Y, and Z and talk to them. They're not going to trust you. I was sharing with you all earlier when we were prepping for this, here I am thinking I'm going to go have a focus group about a particular project that I'm working on, and I'm going to get their feedback on it. And I allowed 1 hour, and they grilled me for 45 minutes to make sure that I was, as they called, the real thing. What are you going to do with the information? Why aren't you going to do this? Why didn't you consider this? And then at the end, this is probably what I took away. Nobody has ever let us grill them like this, and nobody ever comes to talk to us about these issues. And we are more than willing to be involved in whatever way possible. They weren't even asking for some of the stuff that we should be thinking about at the idea conception, the design, at the design point, at the data collection point. We don't always need to do the data collection. There are many programs out there that have trained folks in the community to do the design collection. At the analysis perspective, is particularly if we're talking about qualitative analysis and we're thinking about member checking. And then at the dissemination, I know we're going to talk about this a little bit later, but sometimes in our world, it's about the journals and the manuscripts. People don't read that stuff. So there are other ways to be thinking about that. And so really the power sharing idea is for people that we're going to encounter people that are like, I'm not sharing the power. This is what I do. So then why aren't we thinking about sort of a strategy of how do we train, how do we engage sort of those folks around what their needs are and why there may be issues to bring them along? Then there's another sort of set of folks that are maybe from the community and sort of their needs. And then there's another set of folks that maybe are somewhere in between. So there's 3 different strategies going on. A lot of work, a lot of time, but I bet if we sort of do this consistently and regularly, we will begin to make a difference.
Thanks so much for that, Tammy. I think one thing that was really clear coming from you is, one, what matters to the community looks very different oftentimes from what matters to the researcher. I also think about the healthcare system and the fact that we have researchers like you who are doing kind of the gold standard. I'm trying to put this into a manuscript form to submit to a journal. But so many of our practices and policies around implementing social determinants of health comes from evaluations that may be hyper-local in FQHCs to larger healthcare systems, and that really impacts daily life as well for those patients. And so I'm wondering what it would look like for power sharing with evaluation at that local FQHC, community-based hospital, or even large healthcare system level. And I'll pose that to any of you who wants to jump in.
Tara, I think it really comes down to transparency at the beginning of your process. If you're a healthcare organization trying to implement a program for your patient population or the community at large, you've got to be really transparent with them about what your goals are for the initiative, and be completely prepared that once you share them, that you get shot down by the community, and be okay with it, and be okay with having to make modifications to your original plan. Power sharing is truly that. You have to share. You have to be willing to hear other people's perspectives and incorporate them into whatever you're trying to do as you move forward. And I think that's really hard for folks in research and in sort of healthcare delivery, right? You get a certain amount of money, usually based on a proposal that you've written, and it looks really good on paper. You got the grant and you move forward. But oftentimes, the end user or the patient is not incorporated in that process. And so if you are, granted the opportunity to create something that you think is going to be really innovative and helpful to the community, you better make sure it is and ask. And if it isn't, you'll be really surprised with some of the innovations that they offer that could really enhance what you're trying to do, meet your goal, but ultimately help them. And if that was your true intention to begin with, then you'll get to where you're supposed to.
Thanks for that. Adam, I want to bring you in. I mean, a lot of times we see this approach and see the urgency come from healthcare systems wanting to do the right thing. It's well-intentioned when trying to implement a social determinants of health intervention. The programming in itself is sometimes rushed, so that definitely means the evaluation is rushed. And what seems to be happening is a lot of systems, programs, kind of taking on this savior-designed approach where things seem to benefit the institution a lot more than it benefits the end user. And I'm just wondering, from your experience, working, in healthcare delivery research, how can we push against that power dynamic and promote power sharing?
Great questions. I think there are things that we can do within the research community. I think there are things that we can do within the healthcare community. I think what those things are is hold ourselves accountable to going back to the basics of understanding the processes and understanding the programs and getting under the hood like we talked about earlier. As the evaluation design is being developed, not rushing to just look at the outcomes that we want to focus on, which are often outcomes that may be of the highest value to the healthcare system, right? But being sure to build in process measures and build in ongoing evaluation of not just those outcomes, but the implementation itself, to make sure that the fidelity of the implementation is high to whatever standard your group of external advisors, including participants and community members, has established, right, in that early power sharing process and feedback and stakeholder process. I think those are really important things. So in the work that Artera, you and I did at KP in Southern California, we were very deliberate in measuring how often were connections made, at what point in the connection sort of pipeline. We evaluated a traditional sort of social needs screening and referral help desk for high utilizers. We looked at what was going on at each phase of the connection, the screening and the referral and resource connection cascade, and then reported that. Not just the ultimate outcomes, which were utilization outcomes, but we worked backwards and said, okay, well, how many of the participants that we were aiming to include actually were contacted? How many of those participants, participated actively, had needs, and then ultimately got connected to services that we thought would be useful in addressing their needs and improving their health? And then, we focused as much in the discussion on those process measures, right, as we did on the ultimate outcomes, and we're able to explain so much more about the outcomes that we saw because we'd done that work of looking at what was actually going on. And there was even more that we'd done to understand from the perspectives of the advocates and the participants what the relationships were like and what the interactions were like in ways that weren't even quantifiable in those sort of connection rate process measures. We really understood at a very granular level, a very relationship-based level, how did those interactions operate, and what was the experience of participants, and how could we improve along the way. I'll say one more thing on this before stopping, and I apologize for going on, but there was also an adaptive design, right, to the program. We didn't end up where we started. We took feedback, and this is obvious stuff, but it bears mentioning. We took feedback along the way, and we iterated the program itself, and learned, and were not wedded to the way it was designed initially, because we knew that we were going to learn so much along the way about how to do it better. And being able to do that is everything, especially at this phase of the field where there really aren't gold standard interventions or ways of implementing.
Thank you for that, Adam. I definitely remember that experience very well. When I hear you bring that up here, Etsemaye, and Tammy's thoughts as well, I immediately think about accountability to racial health equity practices within this research and evaluation of social determinants of health interventions. And so I'm really interested in just asking, each of you how you're holding yourself accountable to not creating harm and promoting justice with your social determinants of health evaluation. Adam, you kind of started talking about the process metrics. Being in that position with you, I think that there was even room for improvement in what we did, and the fact that we could have looked based on race, ethnicity, gender, so many demographic categories to understand how people were moving in and out of the intervention. Because to me, if it's not actually reaching the historically marginalized or the historically underrepresented, then we're actually, I don't think we're making inroads when it comes to racial health equity. So I'm wondering if you could even elaborate on that, elaborating out how you can improve the process of thinking through using process metrics as a tool to holding yourself accountable to racial health equity, and are there other ways that you're holding yourself accountable with your research and evaluation portfolio to racial health equity?
Is that question is directed to me, Archie?
That's directed to you, sorry.
Yes, that's a perfect question. And it actually goes back to, I think, a conceptual framing process in the beginning of thinking about, again, with external advisors who include participants and include community members, what are the ways in which power might be inequitably shared, or there might be hierarchy, or there might be issues of privilege that interface with the program or the research that's being done, and then mapping those out, and then actually deliberately embedding in your process evaluation, looking at those differentials, those potential differentials, and saying, okay, for my program, if I'm working on a program that might be experienced differentially based on language barriers, or might be experienced differently based on race and ethnicity sort of and cultural background, how am I building that into my process evaluation and looking along the way to see whether I'm getting differential impact or am hearing different feedback from participants who may be Spanish speaking or English speaking, or historically marginalized, black and brown versus white, whatever the case may be from your conceptual framework. I think if you do that deliberately, and also as a field, right, we begin to expect of one another, and when we're reviewing papers or we're looking at programs, that be part of the design process. Or the grant, submission and proposal process. I think that would go a long way towards actually making that the standard of practice, and it would be a simple sort of evolution of a lot of the things we already do in the research design process that could be implemented and actually have a huge impact in this equity space as well.
Thanks. I guess I'm really even thinking back to what you're saying, Adam, is making me think through the involvement of community, centering community. And, Tammy, you brought up some really good points around getting the information back to the community. And I think that was definitely an approach that you can use to make sure you're, elevating racial health equity in the space. And what's your advice to people if they're really trying to think through ways to disseminate that information back to community effectively? Like what process should they be taking?
Start with the community and ask them. It really is like Adam, there are a couple of things you said. It's iterative. And so maybe you think, I'm going to just sort of put it here. And then you say, maybe I need to be doing something else. Who can I have a conversation with to at least give me some feedback around where I should put this? And oh, by the way, me sending a manuscript to a community is that doesn't work at all. Maybe it's a fact sheet, maybe it's a flyer, but I won't know until I ask. And, I love this idea of sort of being adaptive in some of the work that I'm doing right now. I was 90% sure that I had this particular decision support tool that was ready to go. And they just slashed it apart from the language to the pictures to it is like starting all over again. And yet I know that when we're done with this process in a couple of months, I have something that I can say, this is not mine. I was just the facilitator. And I do think that when you have conversations with different groups of folks, folks who have language barriers, maybe it's not a fact sheet because maybe there's issues of literacy. Maybe there's issues of translation. Maybe it's a podcast. Maybe it's some kind of social media. I think there are so many creative ways for us to be thinking about disseminating our work that's not this traditional way in which we were trained. If we are really truly about equity, if we are really truly about in elevating it in a way that makes sense not only for the researchers but for the populations that are affected, then it really is about putting them first. And, I was thinking, I sat on a community advisory board because, I represented the community that was affected. And you know what? It was a waste of my time. They weren't interested, in my opinion. They had already figured out what they wanted to do, and that wasn't being accountable. Back to, one of your questions about being accountable. Being accountable is really empowering us as community members, really empowering those affected populations to say, this is my data, this is my story, and you have to think about me as you are talking about this, and I prefer to be with you as you're talking about this or coach you about how to talk about this, because so many times we talk about it from a deficit perspective, which is what we talked about earlier. So it's about centering in, who should be there, who should be at the table. Think back to sort of all of us who have done community organizing. The first question is, if this is the big giant issue, who's supposed to be sitting there? And if they're not there, how do we get them there? And what happens after we do that?
I love that. Etsemaye, so many people, building off of Tammy's question, have really asked about methods of capturing the community voice. And I know that that's something that you have done in your work. And I'm just wondering, what advice would you give people in capturing, community conversations? Should you be doing surveys? And then how do you ensure that there is representation of many different experiences and expectations within any community? How are you getting that diverse perspective?
Sure. Going back to Tammy's point, it goes back to making sure that you're doing the work in line with the community. One community member can identify several others that you should be talking to. A lot of the work I've done sort of has been in the qualitative space to really capture the diversity of perspectives that sometimes a survey cannot capture, right? Or a social determinant of health screening tool cannot capture sort of the complexity of what it means to be housing insecure or food insecure. And so the qualitative methods really lend itself to sort of capturing the diversity of perspectives, and to ensure that you're getting different people from the same neighborhood or community, you've got to rely on some of those community leaders to point you in that direction, and create that safe space for you, because as a researcher, sometimes you can't do that alone unless you already have established relationships with them. Going back to one thing that Tammy had mentioned about finding new ways to share your work with the community, I think we have to recognize that community's not reading the journals that we write our manuscripts in, and we should reach out in other ways, but we should also hold our journals to a higher level of accountability, and figure out new ways for them to disseminate the information that we're sharing in a community-friendly way. I don't think we have to reinvent the wheel too much when they have the resources to really push the message out there in a number of different ways. And if sort of our academic community could be better at sort of reaching out to the community in that way, I think we'd all be in a much better place in building these partnerships.
I love that, Adam. I don't know if you have something that you want to add on to that. I just would love to hear, particularly, explicitly thinking through getting this information to Black and Brown and Indigenous populations, because these are the groups that we see, through screening tools, typically, from a racial health equity standpoint, they're screening for the most social determinants of health. They already have this historical systemic oppression placed against them. I don't know what venues or avenues that journals have typically taken to get information out. I just, know my mom is not reading a journal unless my name is on that manuscript. So I'm just wondering, how do you, Adam, any recommendations on how do you get that, building on Etsemaye's point, to those communities that, you all are evaluating and are researching?
Yeah, well, at the journal and publication level, there are lots of creative tools that journals are already using, like the video abstracts and sort of briefs that I think could be adapted in ways that might be more disseminatable, but that it would be up to the journals to figure out, well, how do we build constructive and open dialogue with the communities that we really want to make sure read and understand and are connected to these findings. I think there's actually a level before the journals, though. Etsemaye talked about the academic community more broadly, right? This is a community of researchers and healthcare professionals who are already embedded, oftentimes, right, in the work of serving communities that are marginalized, Black and Brown communities in urban centers. I mean, that's sort of the classic sort of academic medical center location, right, for lots of reasons that I think are relevant to this conversation, but that we won't get into today. But our incentives, right, in those institutions are also not aligned with this kind of public-facing communication, right, and transparent communication. But they could be. If the academic product, right, the currency of academia was not the New England Journal paper itself, but was the impact of the finding, right, on the community that it's relevant to, then all of a sudden you would see, a tremendous shift towards figuring out immediately how to communicate, the findings and make sure that they were scaled, for communities that could benefit most. So that's, I think, where we have the most important and maybe most impactful. I'm not going to say it's the most important, but it might be the most impactful work to do in order to shift how the entire healthcare system and the academic apparatus is oriented towards community engagement and community health improvement. That's where I think we get the biggest bang for our buck in terms of population health equity.
Great. I do want to encourage everyone I know some people have been doing this, but please submit your questions. I'm just trying to integrate as many questions that you're putting into the chat into the discussion as possible. So feel free to go ahead and submit questions. As you're doing that, I wanted to really think through the advocacy piece that you all have been bringing up, especially when it comes to racial health equity practices. I feel like every time we've had one of these conversations, we have talked about best practices and a lot of frameworks and are uplifted and are rooted within, the research and evaluation spaces that you all occupy. And I have to be honest, I know that this panel is very diverse, and Adam is the minority white male in the panel discussion. But in actuality, if I were to go to any type of research event, there are going to be a lot more people that look like Adam. I'm going to have to dig and find the people who look like Tammy and Etsemaye. And honestly, a lot of times I am looking as a Black person for someone who looks like Etsemaye and Tammy. And I just noticed with research and evaluation, what is valued is actually shared. And in traditional social determinants of health research, we see the outcome really uplifted. And we don't see these best practices around centering community voice, addressing systemic inequities, and really applying an anti-racist lens to the work as being best practices. And so how do we start to elevate this work? How do we start elevating the centering of the community voice, the anti-racism work that's required to make social determinants of health intervention sustainable? And I'll start with Tammy. If you could just give any advice on how do we advocate or how do we push for this label of best practices to be associated with the things that we talked about today.
Thank you. So I think like the one thing that comes to mind is no matter where we sit, no matter what setting we're in, no matter what discipline we're in, the first thing we should be asking is the person or population or patient I am thinking about writing about, I'm thinking about writing a grant about, have I found them? Have I talked to them? Where are they? And I'd like it to be more than one, but one person. Can we say, okay, I am thinking about decision support. Is this a good idea? Is this even relevant? So it's not just us sitting in our windows sitting in our offices, sitting in our institutions, sort of saying, oh, this is the issue because this is what the data says. And so for me, the big piece, and then that's the question you ask of yourself. That's the question you ask of your colleagues. That's the question you ask of the folks above you at the administration. Where are the community voices? And that's just one simple question. And maybe we don't like the answer, but if we ask it all the time, consistently, where is the community voice? Where is the community voice? Where is the community voice? If you keep saying that, people are going to get sick and tired of you saying that, and they might be like, okay, let's figure out how to get the community voice in, because that's where it starts. We don't even acknowledge that that's what we need to do. I mean, that's not the first thing we ask when we think about anything that we do, other than when we're doing sort of our practice together. When it comes to research and evaluation, that is not the first question, and that should be the first question. Once that's the first question, then you can think about, okay, well, how do we involve more? How do we design? How do we think about all of it follows, but start with that very first question.
Always well said, Tammy. I want to bring Etsemaye in to really build upon that, but also just thinking about how the practices that we see deployed today in traditional research, could be racist, and, how are we acknowledging that when we started talking about best practices as well, thinking through centering community voice and why that's not elevated, why the anti-racist lens is not elevated. So would love to hear your thoughts.
Absolutely. So if you're at the point in your research where you haven't incorporated community yet, if we haven't commissioned you to do so already, please do. But if you're not there and you're sitting on data and you're about to publish research about a particular community or population, ask yourself, if I was this population, how would I receive this information? How would this affect me? So there's a level of empathy that's necessary as you sort of perpetuate the information that you've collected and analyzed and come up with your own conclusions about, if you haven't incorporated the community. That could have some unintended consequences that could be really harmful. I think there was someone in the chat that asked, why is it important for academia to share their research with community? It's important because oftentimes community has no idea that someone has published a paper talking about their race or their zip code in a way that reflects so negatively upon them that the next time they head to the doctor and they have an encounter, they don't realize that biases have already been placed in that person's mind as they're interacting with them as a patient. And so I don't know if I'm answering your question, Artera, but I think it's really important for us to have, going back to the idea of humility and empathy of what our research is giving to the world and how it shapes it in ways that we don't always think through.
And Etsemaye, just to follow up on that, people talk about, and again, I'm familiar with your research,
right.
So sorry for asking very pointed questions about your research. But a lot of times people believe that there has to be so much work done on building the capacity of community members to engage in evaluation. And I'm just wondering if you could speak to that.
Sure.
And I guess not looking at it on, a deficit end, I think people also don't think that there's a lot of capacity building work that has to be done on the institutions, and to be able to receive, community participation when it comes to the development of an intervention, the way the data should be collected, the way it should be analyzed, and the narrative that should be expressed as well. So I'm just wondering if you could talk about capacity building from both ends, so what you've seen with the community, but also what you've seen on the institutions.
Right. Archer, I think you're touching on some of the work that I did evaluating the partnership between whole person care and all the community-based organizations in LA County that were partnering. And again, it goes back to having this level of humility and recognizing that we as healthcare providers, as researchers, don't have all of the answers. And sometimes the answers lies within a completely different sector that has been doing social determinants of health work since its inception. And we do not have to recreate things. We do not have to medicalize social determinants of health. And so the way that evaluation went in terms of understanding the CBO's perspective was really going to these organizations and just asking them, how do you do your work? And not assuming that their work was less than the work that I do in a clinical setting, and allowing them to show me their way, and then thinking about on my end, how is that different from healthcare? And then you have to have this willingness to sort of want to meet in the middle. They want to meet in the middle. They realize that you have something to bring to the table, but they also recognize all of the flaws you have too, and they'll point them out. And so if you're really about sort of improving yourself as a healthcare provider or researcher, then you should be open and willing to hear this different perspective. And that's sort of what we did with this, gathering the community-based organizations' perspective on this partnership to address social determinants. And then when we were done evaluating and analyzing the data we collected, we went back to the CBOs and said, hey, did we get this right? Because if we didn't, please correct us before we disseminate it to the rest of the world.
Thank you for that. And how are institutions, were they, and when I say institutions, I'm talking about healthcare systems. Like, how is the healthcare system in this process? What capacity building did you have to do to even prepare, them and get them ready?
The healthcare system is trying to hire those with lived experience to help bridge the gap. They recognize that there's a deficiency with them and the community at large. And so they try to hire folks that can help, but there's still a long way to go. And whether or not they take this perspective that we've gathered and make any changes is yet to be seen. But you got to keep doing the work and see what happens.
I appreciate that line. So Adam, I want to, ask you, what do you feel like needs to be done to uplift these needed, community centering, community engagement, equity-oriented practices as best practices? What do you feel like that you can do? What do you feel like others can do?
Yeah. So I think there are ways to concretize and structure the process of engagement and humility and power sharing that Etsemaye mentioned, and that Tammy, has been speaking to as well. So in the process of in every conversation, asking, have you included, participants from the community that you're working with? Have you made sure that their voice is represented? There are structures that serve to make sure that research and healthcare-based interventions are power sharing appropriately and not causing undue risk and harm to communities, right? We call one the Institutional Review Board, right? That is explicitly put in place to protect participants in research. Why don't IRBs have an equity focus, right? Have our sections in IRB, proposals that explicitly call out what are you doing at each stage of the design, implementation of whatever intervention you're doing, and the dissemination, steps that you can be taking to make sure that you are engaging in that again, humility-focused communication with the folks who are working with you in your project, and who are potentially going to be most affected by the results. So that's one thing. There's also, at every level, there are these sorts of structures and institutions isn't quite the right word, but if you look to review guidelines for grants, why isn't there, in the same way there's a specific aims sort of section for most grants, there's an innovation section, there's a power calculation, right, for traditional research grants. Why isn't there an equity, communication, dissemination, and power sharing, right, section for those grant proposals? If NIH took the step of making that a standard part of their grant rubric for what you need to propose, that would become the standard practice for grants, nationwide in many instances in academic grants. Same with, review criteria for certain types of research. So randomized controlled trials, the consort guidelines spell out step by step everything that you need to do in order to make sure that your study of a randomized intervention isn't dismissed out of hand and sent back to you because it was done improperly, because it didn't check the box on the consort guideline. And I'm not saying that we need to distill all this stuff down to check boxes, but we don't also we shouldn't think that there's nothing beyond sort of person-to-person communication or like individual efforts that we can put into place to make sure that this is the standard, right? So all of those things are available to us if we look for ways to change what is taken as a given of what's the standard practice in academic and healthcare-based interventions and research. Then we can absolutely take an equity-focused lens and develop the criteria there, and hopefully that will move us forward.
And I always appreciate, Adam, how even in my work with you love to see how we can create like systemic changes and standardized approaches. I'm wondering how that could look, not with academic research where you just submit that to a journal, but for that person who's in that healthcare delivery system who is charged with developing the social determinants of health intervention within their local hospital. What kind of standard practices can they implement to make sure that their evaluation does some of the things that we've talked about, and even advocate for that to be kind of like a policy or a standard of practice within the healthcare setting? So we'd love to hear your thoughts on that.
Yeah, well, we create guidelines for every other healthcare process. There's no reason we can't create a guideline for this as well. And I think, we've touched on a lot of the steps that could be included in that process. I won't, go through the list in detail here, but I think it would be straightforward to develop a standard practice, either within the healthcare institution that's implementing the particular program, project, or research, or as a field. There are organizations that are research networks or coalitions of individuals who are doing work in this area that I think are actually thinking about these sorts of standard practices already. And it's just a matter of us, those of us who are part of these networks and communities, making sure that we're disseminating that information and doing the work of translation, right, which is done in so many other fields of medicine, from research to practice, where fidelity, right, to a certain set of standards is really important. So I think we could do exactly the same thing there.
Thank you all so much. I think you gave us a lot to, ponder on and hopefully implement within our, day-to-day context. What was really just, a huge call to action to me was just the fact that we cannot go on any further not incorporating community voice and not addressing power dynamics, because it inevitably creates harm. And then we can't use this fear of feedback or lack of time that it takes to involve others as an excuse in getting in these voices, because not including these voices kind of makes our research and evaluation efforts, I guess, even beyond unethical. They're like, it's not valid. And I remembered Tammy really driving that home if you don't have community validating what you're presenting, and that's something that all three of you have brought up, then you have to really question how beneficial it is. Does your work actually do what it says it's doing? And I was listening to, just random fact, listening to Michelle Obama this morning give her speech. And what was really interesting is that she shared that someone's unjustified fear can put others in harm's way. And we have to recognize that we could be doing that, and we probably are doing that if we're not bringing in community voice. And we have to really consider that the people we're conducting research and evaluation on in this field are individuals, as she described, as having suspicions casted on them from the day that they have been born because of the hue of their skin. And when you think about the fact that there's been suspicions casted on them, in so many sectors of life, part of us advancing racial health equity is doing our part to alleviate and remove those suspicions and validating that voice. Because so many people, again, have had these suspicions casted on them from the day that they were born because of the hue of their skin. I just want to thank you all for participating in this panel discussion. There was so much that I got out of it. I hope everyone else got what they needed out of it. Please know that this webinar's recording is going to be available, and we'll be in touch next time for the next webinar in the Intentionally Integrating Equity and Social Determinants of Health Intervention series. So thank you all. Hope you have a great rest of your day, and hopefully we'll get to speak with you all soon. Bye-bye.